Hi, everyone, and welcome. My name is Vanessa, and I will be your WebEx technical support host. Before we dive into today's meeting, I wanted to provide some quick information on the webinar platform. All lines have been muted on entry and will remain muted for the duration of the webinar. Please submit your questions throughout the presentation using the chat panel and select all panelists or hosts if you would like to ask a question anonymously. The webinar moderator will ask the comments and or questions on your behalf at the end of each presentation. When submitting your question, please provide your organization affiliation so that we are able to identify you. Please note we will make every effort to address as many questions as time permits. Your question and comments will be saved following the meeting. If you require technical assistance, please feel free to contact me, the host, via the chat panel, and I'll be happy to assist you. If you need closed captioning, please refer to the link in the chat panel. We also wanted to make you aware that today's webinar is being recorded. This recording will be archived for a later viewing. Now, I'd like to pass it over to Sue Gapster to start today's webinar.
Good afternoon, everybody, and welcome. I'm Susan Gapster. I'm an epidemiologist, and I've been conducting research on alcohol and cancer for many years. I'll be chairing and moderating this webinar. We're delighted that you're able to join us today to discuss alcohol consumption as a target for cancer prevention and control, and the research that's needed to accelerate action in this area. This webinar is part of a series of events and activities that have been organized by the Behavioral Research Program in the Division of Cancer Control and Population Sciences at the National Cancer Institute over the past few years, which includes a small scientific workshop that was held last week and was aimed to identify what we know and what scientific evidence gaps exist on alcohol and cancer. Next slide, please. I'd like to take a few seconds to acknowledge my co-chair, Dr. William Klein, who's the Associate Director for the Behavioral Research Program, as well as this webinar and last week's workshop, as well as the steering committee, the presenters, who I'll introduce later, and the many others whose efforts were tremendous in conceptualizing and organizing these activities. Next slide, please. The goals of today's web presentations and discussions are to highlight what we know and to identify what we don't know in these 4 research areas concerning alcohol and cancer. Following a 10-minute presentation in each area, there will be about 10 minutes of open discussion, so please use the chat box for questions or comments as Vanessa described. Please know that we'll be capturing these remarks to help inform future activities. Next slide, please. I'd like to acknowledge that my efforts are supported by the National Cancer Institute. Next slide. So I've grown to appreciate how complicated it is to study and communicate the role of alcohol consumption on health outcomes. These complications arise in part because alcoholic beverages are legally produced, distributed, and consumed. And among many communities and societies, alcoholic drinking has been a well-entrenched normative behavior for centuries. In the United States, in 2019, nearly 55% of adults ages 18 or older reported that they drank alcohol in the past month. Furthermore, there's been debate regarding the overall risks and benefits of alcohol consumption. Next slide. Indeed, there are numerous health effects of alcohol consumption. Ethanol, the primary alcohol found in alcoholic beverages, is a psychoactive agent that has dependence-producing properties. It motivates recreational consumption, engenders a sense of excitement, sociability, and intoxication. At progressively higher amounts of consumption, it impairs sensory and motor function, cognition, and judgment. The World Health Organization estimates that worldwide, about 5.3% of all deaths every year result from harmful use of alcohol. Harmful use of alcohol is a causal factor in more than 200 diseases and injury conditions, and 5.1% of the global burden of disease and injury is attributed to alcohol. Beyond the health consequences, the harmful use of alcohol brings significant social and economic losses as well. Next slide, please. More specifically, there's been considerable research conducted over the past century on the relationship between alcohol and cancer risk. Based on sufficient evidence from human epidemiologic, laboratory, and mechanistic studies, more than 30 years ago, an expert panel convened by the International Agency for Research on Cancer, or IARC, classified alcoholic beverage consumption as a Group 1 human carcinogen. More recently, ethanol as well as acetaldehyde, a metabolite of alcohol, were also found to be human carcinogens. In addition to the International Agency for Research on Cancer, the World Cancer Research Fund and the American Institute for Cancer Research systematic literature review process continuously updates the epidemiologic evidence on cancer risk in relation to numerous lifestyle factors, including alcohol. Ultimately, this evidence provides comprehensive, quantifiable risk estimates for specific types of cancer, allows us to better estimate the proportion of cancer in the population that is due to these risk factors, and to communicate that risk to patients, public, and policymakers. However, many gaps in knowledge remain regarding the link between alcohol and cancer and how to communicate that risk. Next slide, please. So with this background in mind, now I'd like to introduce our first speaker, Dr. Kevin Shield, who's the head of the Collaborating Center in Addiction and Mental Health for the Pan American Health Organization and an assistant professor in the Division of Epidemiology at the Dalai Lama School of Public Health at the University of Toronto. Dr. Shield will be talking about what we know about alcohol as it relates to cancer risk and the biologic mechanisms underlying these risks. And following his presentation, we will open it up for discussions on this topic. Kevin?
Great. Thanks, Sue. So next slide. So I just want to dive in a little bit into the organizations that look at the causality between certain risk factors and cancer. So we can see that the International Agency for Research on Cancer, the Continuous Update Project, and l'Institut National de Cancer France all state that based on their independent analyses, alcohol is a causal risk factor for cancer. So that's good, sufficient causal evidence that reaches a consensus across a lot of individuals. But when we dive in here, we can see a little bit of heterogeneity. In particular, when we look at esophageal cancer, what we can see is that that signal of risk coming from esophageal cancer may not be due to all subtypes. In fact, when they looked at the specific subtypes, they saw that that signal of risk was coming particularly from squamous cell carcinoma and not adenocarcinoma. There are also other cancers where we don't know whether or not alcohol has an impact on them, in particular stomach, gallbladder, pancreas, prostate, and kidney. This might be due to various different reasons, including that subtype analyses that I previously mentioned. Next slide. So when we look at the biological evidence of how alcohol causes cancer, we can see some clear signals arising. Firstly, we have alcohol metabolism. Alcohol metabolism and its metabolites lead to various different carcinogenic compounds, which can cause cancer themselves. Next, we have the upregulation of CYP2E1, which can interact with other procarcinogens to increase the risk of cancer, not just from alcohol, but from other metabolites of different environmental exposures. We also have alcohol impacting the 1-carbon metabolism pathway, and this impacts DNA methylation. This risk pathway is especially important for people who have low dietary intakes of folate. If you have a low dietary intake of folate, your risk of cancer due to alcohol is going to actually be higher, in particular for breast. We also have a couple of unknowns. Alcohol in the immune system, alcohol in metabolome, and alcohol and its impact on estrogen and that relation to breast cancer is currently unknown, but hypothesized to be a causal pathway in terms of how alcohol causes cancer. Next slide. So I just want to dive a little bit deeper into the metabolism of alcohol, in particular acetaldehyde. We know that acetaldehyde is the main carcinogenic metabolite of alcohol. It's also metabolized by ALDH2, and genetic polymorphisms in that metabolite, the genes that encode that enzyme, can actually increase your risk of cancer because you increase the bioavailability of acetaldehyde. In particular, we notice in people who flush red, so people who are typically Japanese, Mongolian, Thai, Vietnamese, and Chinese have a higher prevalence of these variants that can cause them to have a higher risk of cancer associated with alcohol consumption. Next slide. Next, I just want to note very briefly about alcohol. It produces NADPH and upregulates CYP2E1. in terms of its metabolism. And what happens here is that it's involved in the production of reactive oxygenase species, and these can cause cell damage and lead to cancer itself. Next slide. Next, I just want to highlight the acetaldehyde pathway. We can see that it causes DNA adduct formations through 3 main pathways. Next slide. Now, this slide is actually really important and presents a huge knowledge gap in terms of what we have in terms of the knowledge of alcohol causing cancer. We can see that the metabolism of alcohol causes cancer itself. But for cancers that are caused by alcohol and cancers that are due to other risk factors, alcohol may play a role in promoting tumor growth. So the ingestion of alcohol and the metabolism of it to acetate may actually fuel tumor growth in cancers caused by alcohol, but also cancers caused by other risk factors as well. Next slide. So we know based on the biological evidence that there is a sound molecular basis for how the ingestion of alcohol leads to the development of cancer. So what does the epidemiological evidence say? When we look at the population level, what do studies of people, their consumption of alcohol and their risk of cancer, what do those studies say? Well, what we can see is that alcohol consumption increases the risk of cancer on a per gram of alcohol consumed basis. So it doesn't matter if you're drinking wine, spirits, beer, or other alcoholic beverages, your risk of cancer is going to be correlated to the amount of alcohol you consume, in particular ethanol. We also see that epidemiological evidence has shown that even low dose alcohol consumption increases cancer risk. So for cancer prevention, there is no safe amount of alcohol you can consume. Next, I want to note in particular resveratrol. Resveratrol is this antioxidant that has been promoted by both alcohol companies and the media as a potential molecule that can prevent cancer. But the concentration of resveratrol in red wine is actually very low. A standard drink of wine contains only 1/100,000th of a meaningful dose. What this means is that the cancers caused by ethanol in the red wine will far, far outweigh the cancers prevented by resveratrol, to the point where the impact of resveratrol on cancer risk in red wine is negligible. Next slide. So we know that average consumption in terms of the volume of ethanol you can consume increases your cancer risk. But there's also preliminary evidence that the engagement in heavy episodic drinking, also known as binge drinking, may increase cancer risk, in particular for breast cancer. Next slide. So what about former drinkers? Well, we know if you stop drinking, your risk of cancer doesn't go away. You still have that risk of cancer. But what studies have found is that if you stop drinking, your risk can actually decrease with time. And the same would apply to decreases in alcohol consumption. So if you decrease your alcohol consumption or stop drinking, your cancer risk actually goes down with time. So you experience health benefits by reducing your alcohol consumption or ceasing alcohol consumption. Next slide. So what's really important to look at when you're looking at carcinogens is not just to look at that carcinogen itself, but can it actually interact with other carcinogens? So are there any people who engage in multiple behaviors which increases their risk more than just one risk factor alone? Well, yes, in particular smoking. Alcohol acts as a solvent for carcinogens found in tobacco smoke. And so people who are smokers experience a much higher risk of alcohol-related cancers when compared to non-smokers. Next slide. So another thing I want to note is that when we look at the epidemiological evidence, we're usually looking at individuals when we're talking about risk, but we can also look at the population level. In particular, we can see differences at the global level between countries, but we can also see differences within countries, in particular the United States. When we look at indigenous populations in the United States, Australia, and New Zealand, we can see that liver cancer rates and esophageal cancer rates are particularly high in these populations when compared to non-indigenous populations. Presumably, esophageal is due to both tobacco and alcohol. But when you look at liver, predominantly the hypothesis is that alcohol is causing a lot of that disparity between indigenous and non-indigenous populations. Next slide. So I also want to note the impact of alcohol at the population level in general. We can look at risks, but what matters in terms of prevention is the overall global impact or country level impact of alcohol consumption. And we can see that in the United States in 2014, alcohol had a substantial burden on cancer incidence and death. In fact, alcohol caused 87,000 cancer cases in 2014 in the US. It also caused about 23,000 cancer deaths. So alcohol is having this substantial impact on health through its causing of cancer in the United States. Next slide. It's also important to look at it by subtype, so location of that cancer. Unlike smoking, alcohol doesn't cause the vast majority of any particular one cancer, but it does cause a substantial amount of cancers in each of these categories. And when you add them all up, we can see that alcohol has a substantial impact on cancer incidence and deaths among men and women, both in the United States and globally. All right, next slide. So the presentation that I went through today was part of a larger group presentation, and I just want to acknowledge Elisa Bandera of Rutgers Cancer Institute in New Jersey and Vasilis Vasilou of the Yale School of Public Health, who also constructed these slides and presented alongside me. Thank you. So these are the etiology topics that we discussed during those times, and we can see that we highlighted various knowledge gaps, and I can let you go through those on your own.
Thank you, Kevin. So we want to open this up now for anybody to ask any additional questions. You know, you can ask questions as it relates specifically to these various topics that we have listed here. If you have any specific questions for anything that Kevin has presented, go ahead and put those in the chat box, and we will, you know, make sure that Kevin has a chance to respond to you. So I think, you know, one thing, Kevin, that I want to, if you don't mind, I'm going to add a little bit to Kevin's presentation is when Kevin presented the work by a colleague of ours at the American Cancer Society that estimated that burden of disease due to alcohol consumption in 2014. One of the things that jumped out, I think, in the publication that figure came from was that for breast cancer specifically, the proportion of cases that are due to breast cancer was 16%. And I don't know, Kevin, if you've ever thought anything about that, but to me that was kind of more surprising than I think I would have thought.
Yeah, it highlights a really important factor, and that is men typically aren't at risk for breast cancer. They do get breast cancer, but it's a very low number of breast cancer cases. And what this shows is that women are disproportionately affected by alcohol per gram of alcohol consumed. So per gram of alcohol consumed, women actually experience more cancer or a greater risk of cancer compared to men just because you have that breast cancer in there. And so when you look at the population level of alcohol consumption, men typically consume a lot more alcohol than women do, but women actually experience, it depends on what country you're looking at, but almost equal amount of cancer burden compared to men.
All right, we do have a couple of great questions. So the first one is, can you just explain a little bit of the difference between the squamous cell carcinoma and adenocarcinoma of the esophagus in terms of alcohol use? And I guess what type is more common? And maybe you can even talk about how maybe there's been some shifts in the different types of cancer, the different esophageal cancers and their risk factors over time.
So I'm not an expert on esophageal cancer and the squamous cell carcinoma compared to adenocarcinoma. But my basic understanding is that the squamous cell carcinoma occurs in the upper aerodigestive tract and the adenocarcinoma is towards the stomach. And the mucosal lining of the stomach and the adeno area of the esophagus may have a protective effect on alcohol's impact on those cancers. However, there is preliminary evidence that alcohol may be a risk factor for stomach cancer and may be a risk factor for adenocarcinoma as well. In terms of heterogeneity in the incidence, I'm, again, not an expert in the geographical disparities between adenocarcinoma and squamous cell carcinoma, but it's mainly determined based on differences in the distribution of risk factors associated with both.
Great. Another, I think, interesting question that came up is, can you just elaborate a little bit on the biologic interaction of alcohol and tobacco, for which the effects appear to be synergistic, the upper aerodigestive tract cancers, for example?
Yeah, so this is really interesting, and there's emerging evidence on it, and we don't know whether or not alcohol has a synergistic impact with breast cancer, because we know that tobacco is related to breast cancer and alcohol is related to breast cancer. But for the upper aerodigestive tract, we can see this synergistic interaction between tobacco smoke and the impact of alcohol on cancer. So if you do both, especially smoking while drinking alcohol, you have a higher risk of various different upper aerodigestive tract cancers. Now, another area that we're also looking into, not just tobacco smoke, but chewing tobacco. And this is especially important for compounds like BIDI. And it's fatal quid in India, where people chew it and then they drink. There's emerging evidence that we're looking at through various different cohort studies that alcohol actually may interact very, very strongly with chewing tobacco as well. So overall, what we see is a high co-occurrence of these two risk factors, smoking and drinking. So people who smoke tend to drink quite heavily and drink while smoking. And that actually leads to this interaction that greatly increases their risk of upper aerodigestive tract cancers.
Great. There was a question and a comment there's a question in here that I'm going to quickly just jump in and say that more information will be coming. So have there been any studies that have examined the trends of alcohol consumption in cancer survivors? And our next speaker will actually address that question. But then I'm going to go back here, a quick one, because I know you can answer this pretty quickly, is associations between alcohol and breast cancer specific subtypes.
So there is emerging evidence that there is a difference in the subtypes of alcohol and breast cancer, but evidence on that is still preliminary. In terms of the power to detect those differences, what you need is, what you can see right now is you can see significant associations with certain subtypes and non-significant associations with other subtypes. But where the power is missing is getting that risk difference between subtypes. So there's one thing to say, yes, there's a statistical significant relationship. There's another to say there is a difference between the risk between two subtypes. So right now we can say that there looks to be one, but the power to detect the significant difference between subtypes really isn't there right now, and should be answered in the future.
Okay, great. Also, there's, I think this will be your final question, and I'm just going to answer some process questions that are in here. Someone's interested in patterns of consumption, for example, binge drinking, drinking with meals, other patterns of consumption. Do you want to just comment on that?
So the patterns of consumption are important for breast cancer, and that's mainly because they think that the binge drinking influences hormone levels. Drinking with meals is mainly due to injuries. I'm not quite sure if any study or biological study has looked at whether or not drinking with meals would decrease the bioavailability of alcohol, thus leading to less drastically altered estrogen levels. But right now, the research really is focused on binge drinking and not drinking with meals.
Great. Perfect. And then there have been a couple questions about making the slides available. And there will be a link to this entire webinar on the NCI website at some time in the near future. So if you want to go back and review any of these presentations, those will be available. So with that said, thank you very much, Kevin. And I'll go ahead and go on to our next presenter. And that is Dr. Noelle LeConte, who is an Associate Professor of Hematology, Oncology, and Palliative Care in the Department of Medicine at the University of Wisconsin. In medicine, Dr. LeConte will be presenting on the health effects of alcohol consumption during and after cancer treatment. And there were several questions for you following this, so thanks, Noelle.
Great, thank you. Yes, so as you heard, I am an oncologist, and so I'm going to be speaking specifically about the role of the oncologist and how we talk to cancer patients about alcohol use. But I do realize that there already is a lot of research around primary care and the role of the primary care provider in controlling alcohol use. So with that caveat, I'm not going to be touching on primary care, but they clearly have an important role to play here. I also would like to thank Dr. Abena Brewster from MD Anderson, who co-led this session with me during the closed meeting. And some of these slides are hers as well. So with that, first slide, please. So I'm going to broadly cover two areas. One is the association of alcohol with cancer recurrence and cancer-related mortality and overall mortality. And then I'm going to pivot a little bit and talk about what do we know about alcohol and how it affects cancer treatment. Next slide, please. So first of all, talking about cancer-specific mortality, it makes sense to look at the 7 alcohol-associated cancers. It would stand to reason that those cancers would be most affected by continuing to drink or use alcohol. So this is a meta-analysis by Lee and colleagues, which showed a clear dose-response relationship of alcohol consumption and recurrence for both esophageal squamous cell carcinoma as well as head and neck cancers. You can see that the more people drank, the higher their recurrence, and the upper aerodigestive tract cancer mortality was a relative risk of 2.01 for any use, and that went all the way up to 3.63 for heavy use, which was defined as greater than or equal to 50 grams of ethanol per day. The figure here shows both the studies that were included, but also the weight of the risk, and I included the figure for the highest level of alcohol use. Next slide, please. So this shows the risk of what are called second primary tumors, and these are important, especially in the head and neck cancer and esophageal cancer, where there is what's called a field effect, meaning that the entire mucosal area is exposed to the carcinogen. We see this a lot with HPV exposure, which is human papillomavirus, tobacco use, and also alcohol. So what you see here by Doe, a study by Doe and colleagues, was that in 1,181 patients, who were enrolled in a placebo-controlled chemoprevention trial of cis-retinoic acid. 17% of participants had a second primary tumor, meaning a brand new head and neck cancer. And what they saw in this study was that those who drank alcohol had higher rates of second primary tumors, and that this rate of second primary tumors was highest in those who both drank alcohol and continued to smoke tobacco. So the adjusted relative risk for secondary primary tumors among patients with continued alcohol use was 1.3, or said another way, 30% higher than non-drinkers. This study specifically does not address cessation of alcohol after diagnosis, but I will go into some of those figures in a little bit. Next slide, please. Looking then at breast cancer, which is one of the alcohol-associated cancers, the studies are a little bit more complex and more difficult to draw clear conclusions on. I summarized the larger studies on this slide, and you can see there are 4 large studies that do have conflicting findings. For example, in the collaborative breast cancer study, there was no effect on recurrence with continuing to drink alcohol. However, this study did not look at special populations, which you heard from the prior speaker is an emerging area of interest. In the Danish study, the investigators found a modest but significant association between pre-diagnostic alcohol use and breast cancer recurrence, with a median follow-up of 6 years after the date of diagnosis, looking at both frequency and duration of alcohol use, but there was no effect seen on breast cancer mortality. As an oncologist, I would tell you 6 years of follow-up is probably not long enough for breast cancer recurrence, where we can continue to see recurrence even 20 years out from diagnosis. In the After Breast Cancer Pooling Project, a whole cohort analysis did not show any association with ongoing alcohol use and recurrence, but a subsequent study looking only at postmenopausal estrogen or progesterone receptor positive patients did show an increased risk with continuing to drink alcohol. And that is the subtype of breast cancer that we would predict as clinicians would be most likely affected by continuing to drink alcohol. So across all of these studies, there are significant methodologic concerns, including relatively few cancer-specific recurrence events, relatively low rates of alcohol use across all the studies, and many studies that use only pre-treatment alcohol use to predict recurrence after diagnosis. So this is an area of much needed additional research. Next slide, please. The bulk of the data would suggest that it's postmenopausal women with this ER/PR positive or estrogen receptor positive breast cancer that would be most affected by continued alcohol use. So I thought it would be helpful to go through the LACE, L-A-C-E study. This specifically included 1,897 study participants, all females, diagnosed with early stage breast cancer between 1997 and 2000. And they were recruited on average 2 years after their diagnosis, primarily from the Kaiser Permanente Northern California Cancer Registry. Alcohol consumption was assessed at entry into the cohort study using a food frequency questionnaire, and then hazard models were used to estimate risk of recurrence, and they were adjusted for all the known prognostic factors. So among postmenopausal women who consumed 6 or more grams of alcohol per day, they had an increased risk of recurrence with a hazard ratio of 1.51, but they also had an increased risk of breast cancer-related death with a hazard ratio of 1.72. And there was, again, a dose-response curve seen with greater alcohol use and increasing rates of recurrence in breast cancer mortality. Other significant factors with alcohol use were obesity, ER-negative status, and postmenopausal status, with higher rates of breast cancer recurrence in all three groups. I presented mortality in the parentheses, and you can see that the ER-negative category did not retain significance for mortality, perhaps because of a very small number of events, in this case only 28 events. Next slide, please. Looking then at contralateral breast cancers, there isn't much data there, but the data we do have does seem pretty clear that continuing to drink alcohol increases your risk of second breast cancers. So this is a population-based nested case control study, again by Lee and colleagues, where we learned that the risk of second primary invasive contralateral breast cancer, so that is to say on the opposite breast, done at the Fred Hutchinson Cancer Research Center in Washington State. They found that obesity, a consumption of 7 or more alcoholic beverages per week, and continuing to smoke were all associated with a risk of contralateral breast cancer, compared with women who consumed fewer than 7 alcoholic beverages per week, or were never or former smokers, or women who consumed over 7 drinks per week, and were current smokers, had a 7-fold elevated risk of contralateral breast cancer. Again, we see this additive or synergistic effect of smoking tobacco products and alcohol use. Next slide, please. Looking then at colorectal cancer, there have been several studies trying to understand the relationship between alcohol consumption and colorectal cancer, and I would say the conclusion is that they have been mixed. One study observed that heavy drinking was associated with poor overall survival, but the majority of studies have demonstrated no association between alcohol drinking and colorectal cancer outcomes, or even have suggested better overall survival, but it was not statistically significant for that one study. There was a recent meta-analysis of cohort studies which included over 200,000 cancer survivors, and it did show a statistically significant 8% increase in overall mortality and a 17% increased risk of recurrence in the highest versus the lowest alcohol consumers. Really, we need more evidence here to clarify the impact of continuing to drink alcohol on colon cancer outcomes. The final study to discuss is the nutritional questionnaire, which was administered to patients during a randomized phase 3 chemotherapy study looking at 2 different regimens of chemotherapy after surgery for stage 3 colon cancer. And that study was funded by the National Cancer Institute and is called N0147. There they were able to show that type and quantity of reported alcohol use was not associated with recurrence of colon cancer. Next slide, please. When we look at all cancer survival, independent of whether it's an alcohol-associated cancer, we do see that in this large meta-analysis of various Western diet studies, continuing to drink alcohol, especially at high rates, is associated with an increased risk of cancer recurrence with a relative risk of 1.17. When only data for post-diagnosis alcohol intake was retained in the analysis, the results remained unchanged, suggesting that continuing to drink does affect your overall cancer survival. As you can see from the table that's presented here, there were no other analyses around the Western diet pattern that was associated with cancer survival. Next slide, please. Pivoting then to what do we know about alcohol use and the effect on cancer treatment. First of all, we know that many cancer patients continue to drink. First of all, about 34% of cancer patients exceed the moderate limits, which, just to remind us, is 1 drink a day for women and 2 drinks a day for men. Alcohol abuse is associated with psychiatric conditions, which can also complicate cancer treatment and cancer treatment adherence. And alcohol use is predictive of malnutrition and increased susceptibility to bacterial infections after surgery and poor overall outcomes. Next slide, please. Diving a little bit deeper, alcohol clearly has been associated with worse outcomes for surgery, including increased rates of surgical complications, pre-surgical risk that is increased due to concurrent cardiovascular disease and liver dysfunction, especially cirrhosis, that can complicate surgery, but also chemotherapy and radiation. And then smoking and alcohol use during or after radiation for head and neck cancers has been associated with an increased risk of a severe complication called osteoradionecrosis of the jaw. Next slide, please. You saw a similar slide to this from Dr. Shields, and our conclusions are largely the same. So what we tell patients is if you stop drinking alcohol now, you will see a benefit in terms of overall cancer risk, but it does take about 20 years to really reach pre-alcohol consumption levels. So there is a benefit to stopping drinking, but it does take a while to see those benefits. Next slide, please. So we do understand as oncologists that we have an important role to play in talking to patients about their overall health, but especially around alcohol use. About 30% of participants in a head and neck cancer cohort did lower their alcohol use after diagnosis, after counseling from a trusted provider. So we think that this is a real opportunity for oncologists to help patients be more healthy and live healthier lives. The problem is there really is not a lot of literature about the best way to identify these patients, the best electronic health record platform in which to use to help identify these patients, who is the right one to ask them about alcohol use, and what is the best way for us as busy oncologists to counsel our patients about alcohol use that will be most likely to lead them to succeed. Next slide, please. That was my final slide, but I'm happy to open it up to questions. I saw there were lots of questions already percolating in, so I'll just Sue.
I'm going to jump in before we go to the questions and really quickly answer that question that came up about when these slides might be available. And to be on the safe side, we'll just say around 3, maximum 4 weeks, hopefully. And then a question that's come in both during your talk, Noelle, as well as in Kevin's talk, and that is reconciling the potential lower rate of all-cause mortality associated with quote-unquote moderate drinking as compared to the increased risk of cancer. And so I just want to comment that there's a wonderful paper published by the Global Burden of Disease folks that actually attempted to look at all of the confounding, bias, misreporting, variability in reporting of across the world, essentially, on 23 different health, in relation to 23 different health outcomes. And when you actually don't try to compare necessarily one outcome to another, but actually look at all health outcomes that were assessed, and while doing their best to manage all these potential confounding, statistically manage and assess and control for all these potential sources of variation. They found actually that there was no safe amount of consumption for the total burden of disease assessed. In that study, I think it is important to recognize that there was a lower risk of ischemic heart disease with very low amounts of consumption, and that was on a weekly basis. And so we still have to look at, but there are other studies that have looked at genetic factors that play a role in drinking that don't necessarily support that. And so I would say that there is still a lot of work to be done to look at, we know a lot, and we're here to talk about cancer, and we know a lot about the alcohol and cancer associations, and we're here to continue to focus on that. But it is always important to keep in mind that we don't think in isolation about overall health. So I wanted to make sure that I addressed that. And anyway, so are there data on alcohol and its impact in cancer patients and treatment by race or ethnicity?
So there is. It's quite fair, I would say, and this would be an area we would love to see more research. We know that women are less likely to use alcohol cessation services, and we know that alcohol use in general is highest amongst white patients. But beyond that, that's pretty much the total sum of what we know. And so we really, really need help. I heard this loud and clear over the conference. We need help identifying these patients and learning how to talk to them. Most patients get asked about alcohol use once and then kind of never again. It sort of lives in the EMR and never gets readdressed.
Okay. Are there data, any additional information to share about alcohol use during and after prostate cancer treatment?
Yeah, good question. There is no specific high-quality study that I would refer a prostate cancer doctor or patient to. I think we can look at some of these all-cancer analyses, and we can also say that counseling patients about ongoing alcohol use likely is good for their overall health, but there's nothing specific to prostate cancer.
Okay, and then there was a kind of an additional question asked about the interaction, if you will, of alcohol during treatment and health outcomes. And perhaps at the same time, you may want to just mention, what about also ongoing sorts of like chemotherapeutic agents you might take after, your treatment, if you will, like tamoxifen, long-term tamoxifen use.
Right. So, thank you for having me emphasize this, because this was really important. We know nothing about it. So we think that alcohol likely could affect the absorption of oral chemotherapy or oral supportive care medications via the way that alcohol can affect enzyme production in the human body. So it would stand to reason that it's highly likely that it would affect things like tamoxifen or other similar drugs that we use to block hormones in breast cancer. It likely affects the way that anti-nausea medicines or pain medicines are absorbed by people. And so we really would like to understand that better to help our patients understand the choices that they can make. We also know almost nothing about chemotherapy effect. However, when you give chemotherapy intravenously, it's pretty unlikely that anything you take by mouth is going to override intravenous.
Thank you. And then I think our final maybe question that we have here, is there any research to suggest that patients in treatment are more likely to benefit from alcohol treatment services integrated into the cancer center, the referral?
No data that I'm aware of, but it stands to reason that that's probably a pretty ripe opportunity. I know a lot of cancer centers have recently kind of reinvested in tobacco cessation, and so one point that came out of our discussion over the 3-day conference was that an opportunity for us as oncologists to also address alcohol use. So great point.
Yeah, and I think related to that, it's, I think the answer here is there are no data regarding the effectiveness of brief interventions in terms of timing of delivery, prior to treatment, during treatment, post-treatment.
Right.
Yeah.
But patients often make behavior changes solely based on their cancer diagnosis, so it might be a really great time.
Yeah. So, Noelle, you might have touched on that, but maybe just remind us that, when we think about, I'll call it recidivism, as you said, people make those behavioral changes right at the time of diagnosis or during treatment. But, we know a lot about many years out about changing behavior. And then, you almost want to think about the very, very heavy drinker who has head, neck, or esophageal cancer differently, perhaps, than your low-level drinker.
Right. I don't think we know, Sue. We don't know about patterns of use. We know that in general, the peak time for people to drink is sort of young adulthood, 20s and 30s. We know that people that drink as children or young adults are more likely to be heavy drinkers as older adults. And so that is why I think a key strategy of cancer control is focusing on youth drinking. Mm-hmm. But I don't think we really know, and I think the point that's not really being discussed yet is just the immense availability of alcohol in the U.S. It's very, very hard to avoid it, even if you wanted to. And so thinking about things like advertising, access, outlet density, we're seeing lots of changes with COVID where people can get alcohol much more readily than they could pre-pandemic. How is that going to affect cancer recurrences, incidence, mortality?
And thank you, Noelle, for bringing up COVID. I think that's a really important issue for us all to keep in mind for the cancer patient from so many realms, not just alcohol. And that's an issue that cuts across, as you brought up, the policy issues around it, which segues very nicely into our next speaker. Thank you. I'm going to go ahead then and introduce our third speaker, Dr. Timothy Naimi, who's the director of the Canadian Institute for Substance Abuse Research at the University of Victoria. Dr. Naimi will be discussing policies relevant to reducing the health effects of alcohol consumption. So, Tim?
Oh, thanks, Sue, for having me back, and thanks for the people tuning in. So go ahead and advance the slide, please. Next slide. So I'm just going to touch briefly, as you mentioned, on alcohol policies in cancer. Next slide. Well, I think this is the way I think of alcohol policies in cancer as kind of a conceptual framework. And so we start with alcohol policies. We can think about them as sort of overall policy environments. All states, for example, have dozens of policies in operation at any one time. We can also think about them as related policy subgroups like pricing policies or physical availability policies, and then key individual policies like tax. Then when we think about this relationship, we need to think, okay, how does that translate down to alcohol consumption? And as we know, most of the studies of alcohol consumption in cancer are based on the total amount consumed per person, which is often changed into an average. But there's also the impact of patterns, and there are theoretical and some empirical evidence to suggest that patterns also matter for cancer. And then we think about the cancer part of the equation, which can be kind of all the alcohol-related cancers together, or for different individual cancer types. So we have to understand kind of all these relationships to have a full handle on it, and that's why this is an exciting area for future research. In the bottom box, we also talk about there's lots of other factors that can interfere with or can combine with these basic three boxes on top. Next slide, please. So for some people in the audience, when we talk about effective alcohol policies or policies, they may not be aware of what we're talking about. So this is an example of the effective alcohol policies that are recommended by the Community Guide, which is convened by CDC. These include things like, and these are their effectiveness in terms of reducing excessive consumption based on amount or pattern or outcomes, so increased alcohol taxes, regulation of outlet density, which Noel touched on a little bit before, dram shop liability laws, the idea that if you overserve someone, you can be held liable for that, avoid privatization of alcohol sales, or in other words, maintain state monopolies, maintain limits on days and hours of sale, and enforce laws prohibiting sales to people under the age of 21. So those are some examples. Next slide. And these are broadly, consistent with what works in terms of the World Health Organization. What are the best buys, the most effective and the most cost-effective interventions? These include, again, alcohol taxes and other price controls. And we see around the world now that in addition to taxes, we have the rise of minimum unit pricing for alcohols, which puts a floor on the price of cheap alcohol in particular. Again, the physical availability, and then advertising and other marketing. Next slide. So those are on the policy side. And actually, if we can jump back one slide, if that's possible, Vanessa, that would be great. But, sorry, I'm going to go back. Perfect, thank you. So I should mention for all of these policies, there's good evidence, both alone and in combination, that these can lead to actual changes in consumption that you can measure, not just among study populations, but among the entire population through surveys or registries of deaths or alcohol-related problems like alcohol-related motor vehicle crashes, alcohol-related homicides and suicides, and these sorts of things. Next slide. So if we think now to the next part of the equation, which is how does consumption, that middle box, relate to cancer? Kevin Shield has already touched on this. This is most of what we know about this is based on individual level studies from meta-analyses of individual level risk. And this is taken from a meta-analysis by Bagnardi et al., just showing the relationship between alcohol consumption on the x-axis on the bottom and the risk of cancer on the y-axis for selected cancers shown here. Next slide. So again, we have lots of evidence about individual level consumption being a risk for alcohol attributable cancers in the population. And that's where we use something called population attributable fraction or indirect methods. So if we know, because as Kevin mentioned, none of these cancers is 100% alcohol related, right? They all have multiple risk factors. But we can essentially calculate based on the risk relationships with alcohol and how many people are consuming at different levels in the population, we can actually calculate the number of cancers in a population of a certain type that are actually due to alcohol. But then below that, we also have some, although less, evidence of population level, not individual level, alcohol consumption and rates of alcohol-related cancer mortality. So for example, if you look in European countries with higher per capita consumption in the population tend to have higher rates of alcohol-related cancers. And in those same countries, changes in that consumption also can be associated with changes in those same cancers. Next slide. So if we think about alcohol policies in cancer, so that's jumping all the way from the alcohol policies in cancer or alcohol policies on the left to cancer on the right. I mean, first of all, I think if policies can affect consumption and consumption can affect cancer, then alcohol policies can affect certain cancers. So this is often examined through modeling studies, which can quantify this for taxes. It's also important to think about what about like aggregate measures of alcohol policies, because as I mentioned before, all these policies exist in groups. Next slide, please. And so our research group has taken a very kind of preliminary stab at this. and this was presented at a cancer conference co-hosted by Yale and NCI. And this was looking at the relationship between alcohol policies and alcohol attributable cancer mortality in the United States. Next slide. So basically, our team has developed these alcohol policy scale scores. They consist for each of the states of a score based on 29 policies, weighted by each policy's relative efficacy and degree of implementation in states. And we relate these state APS scores, related them to annual alcohol attributable deaths for 6 cancer types in U.S. states. Next slide. And this is just a slide showing the variability in the policy environment based on those 29 policies in U.S. states, where the lighter colored or more yellow states have less restrictive or weaker policies, and the darker and red colored states have more restrictive policies. So there's quite a bit of variation in these policy environments between U.S. states. Next slide. So this just shows what we call the crude association between state alcohol policies and alcohol attributable cancer mortality based on those 6 cancer types. Along the bottom, we have the alcohol policy scale. As you move from left to right, the policies in those states are more restrictive, yielding lower alcohol consumption, and then the cancer mortality is on the y-axis. Next slide. And when you put these into like logistic regression models and adjust for a variety of state level factors, we also were able to look at the associations between a 10% difference in the state alcohol policy scale score, which is about a kind of a typical difference between states, and the relative differences in alcohol attributable cancer mortality. And so that shows that for a 10% increase in the restrictiveness of the policy environment, there's about an 8.5% reduction for all of those cancers combined in terms of the number of alcohol attributable cancers. Next slide. But you've heard a lot of things about how policy can affect consumption and is the key driver of that, but it's hard to change policies. So this slide again is from our research group looking at the change in U.S. policy subgroups over time, not all of them. But the key thing I would draw your attention to is the solid dashed line running along the bottom that's basically flat. And that that dashed line at the bottom that's flat represents all those population policies that have the greatest proven efficacy, taxes, outlet density. So those haven't changed. The line that goes up, the dashed line that goes up on the top, shows the change in policies related to impaired driving. So, as a country, we've tended to implement those over time, but in terms of those kind of best buys, we've not really made much change over the past 20 years. Next slide. This also shows that for some of them, we're actually going down. These are inflation-adjusted taxes. Next slide. So in summary, there's very strong evidence that alcohol policies affect alcohol consumption. There's very good evidence, particularly at the individual level, that alcohol consumption affects cancers. Because policies can affect a population consumption, changing policies is the cornerstone of a public health approach to cancer prevention. But as we mentioned, changing alcohol policies is different. And additional research about policy-cancer relationships would be helpful not only to inform the science, but to inform policy development as well. So with that, next slide and last slide, I want to acknowledge some grant support from NIH for some of the research presented and the co-authors there. And also the panel from the meeting previously included, this includes a lot of thoughts from David Jernigan, Penny Bucks, Alicia Sparks, and Maristella Montero, who are not with us today for this presentation. So thank you.
Thank you very Thanks, Tim. So again, here are some potential discussion topics. If you have others that you want to bring up in the chat, feel free to do so. We have several minutes to be able to pick Tim's brain. Anything coming up? I'm not really seeing anything here. What is it? So we have one. What's a good lag between the implementation of policy and looking at cancer incidence, Tim?
Yeah, that's a great question. And it's a good thing because it's the only question so far. But so Kevin talked a little bit about this. There's actually a couple of lag times involved. There's the lag time between policy, affecting consumption, and then there's the lag time between consumption affecting cancer. So typically, when a policy is enacted, there can be a delay. First of all, it gets passed and then it gets enacted, but it takes a little bit of time for that information to kind of filter down to the public or for the policy to be actually implemented. So, so typically in our studies, we will try several different lags, but usually we use a 1 to 2 year lag as the most common one. And then, another reason, then there's the lag time between, changes in consumption and changes in cancer. And that's actually interesting as well, because on the one hand, you think, well, cancer takes a long time to develop, but in fact, it looks like lag times anywhere from 1 to 10 years can be appropriate. And that may be because that for any person, there's a whole bunch of people at different levels of progression of a precancerous to a cancerous state or a preclinical to a clinical diagnosis of cancer in the population. And so a lot of times when you squeeze the tube of toothpaste on one end, the toothpaste will come out the other end much more quickly than you might expect. So again, I think it's legit to, even for that, to look within, several years of the consumption change.
So we also have a question about your study that looked at the 10%, showed associations with the 10% difference in the ATS score and the relative difference in mortality rates. Did you look at that by race ethnicity of the mortality rates? Right.
Yeah, for that one, we were not, we were not able to because we didn't have we did not have the composition. This just models the number of cancer deaths attributable to alcohol, but can't really provide that on a race-specific basis. So for that study, we were not able to do that.
And how is accountability best incorporated into policy? Not sure if you have thoughts about what accountability means here in the...
Yeah, I'm not sure what accountability
is referring to.
I'm not sure what it's referring to.
And maybe Karen, if you can add to that. So we'll go on to the next question. In the marketing and advertising realm, do you know of policies to limit pink ribbon labeling on alcohol? Are there any data on how this affects consumption or cancer?
Right. Well, I think there's nothing, most of the policies that we refer to are public policies, so they're passed either in the form of laws or promulgated as regulations. And so I don't think there would be anything of that nature that would limit pink ribbon campaigns. So I think that's more of a matter of awareness for the like NGO communities or for people to even feed back to organizations, including those that are interested in cancer prevention, that pink label campaigns may not be appropriate or helpful.
And there's a couple of great questions here, which I think you can definitely answer and would be great to pick your brain on. Of the policies, which ones do you think would have the greatest bang for the buck in reducing consumption and cancer risk?
Well, again, I think it's overall consumption. So again, I would go back to those same slides in terms of ones that were reviewed by the CDC, by the Community Guide to Preventive Services, and I worked on that for some time. But the big ones are restrictions on price. So those are things like taxes, but also things like wholesale price restrictions, where, for example, a wholesaler can't sell to a retailer below cost. So those price ones, and the physical availability policies. So those would be kind of hours of sale, number of outlets, and even laws that prohibit the sale to underage persons. So those prices and physical availability policies would be the keys. Marketing is also very important, but in the U.S., because of commercial free speech and so forth, it's harder to have more impactful marketing restrictions. So that's also potentially important.
Yeah, and I think this next question I'm going to ask is kind of down the list, but I think it plays well into what you've been thinking about is are overall cancer rates lower in countries where alcohol drinking is prohibited?
Yeah, that's a great question, and I do not know the answer to that question. I don't know what the answer to that is. Maybe somebody else does.
You think that would be very confounded, right?
Yeah, well, I mean, that's a good point. I was going to, so yeah, that could be tricky. In some of those countries, there may be more or less tobacco use, and it would also might depend on, in certain regions of the world, certain cancers are more or less prevalent. So I know more about developed countries being provincial, I guess, and in those cases, mostly more people tend to drink. So I'm not. It's a very good question, and I should know more. And I'm sorry that I don't feel like I should. I can address it better.
That's okay. I think we're going to go move on. Tim, thank you so much.
Okay, thanks.
And we're going to go to our final speaker, who is Dr. Courtney Scher, who's an assistant professor in the Center for Communication Health in the Department of Communication Studies at Northwestern University. And as a communication expert, Dr. Scher will be speaking about public communication efforts to address alcohol and cancer risk. And I think this is a great area because many of us who've been working in this area for a long time know that this is a challenge, and the alcohol-cancer link has been underappreciated. So,
thank you so much, Sue. Next slide. Perfect. My brief overview is not exhaustive of all communication modalities and challenges, but instead focuses on public communication of alcohol as a carcinogen, and will conclude by highlighting some potential challenges when communicating the association between alcohol and cancer risk. In 1988, the World Health Organization declared alcohol a carcinogen. However, global public awareness of this association has remained low. According to data from the Health Information National Trends Survey and the Cancer Risk Awareness Survey, Americans' awareness of this association has fluctuated between 22 to 46% over the previous 15 years. Increasing awareness is critical for informed decision-making, gaining support for policy change, and modifying health behavior. Next slide, please. Weissman and Klein examined data from the Health Information National Trends Survey to better identify characteristics associated with awareness to determine groups of people who may be in greater need of an awareness intervention. Participants could respond yes, no, or don't know when asked about awareness that heavy alcohol consumption increases cancer risk. Characteristics previously correlated with awareness, as well as novel characteristics, were examined. Next slide, please. Adults less than 60 were less likely to report don't know, and those with low self-efficacy were more likely to respond don't know. Those who believed everything causes cancer, or in other words, cause ambiguity, and those who seek out information about cancer were more likely to respond yes. Age was the only personal characteristic previously identified in the literature. However, in this study, those of younger age were more likely to respond definitively, but not affirmatively, about alcohol and cancer risk. The finding of novel characteristics correlated with awareness in this study draws attention to variables that may need to be further examined to inform message strategies. But importantly, the sweeping low levels of awareness and lack of associations between other personal characteristics support the need for broad public health campaigns that address alcohol's association with cancer in the United States. Next slide, please. Most studies and campaigns in the United States have focused on underage drinking and driving, or binge drinking. While important topics, the focus of these studies may obscure the risks of even low-level and moderate drinking on cancer development. Aside from a few descriptive studies, or studies where alcohol is a sub-focus, the carcinogenic effect of alcohol has not been a priority area for communication research or campaign development. However, research conducted in Canada, Denmark, the UK, and Australia may provide insight. Efforts in these countries have focused on increasing awareness by leveraging anti-tobacco campaign success and following World Health Organization guidance to use container labeling as a means to raise awareness and gain support for policy changes, because policy changes ultimately have the greatest effects on behavior. Next, I will briefly review a sample of these studies. Next slide, please. A large-scale social media campaign to increase adults' awareness of alcohol as a carcinogen was launched in Denmark in November 2017 over a period of 14 days. Cross-sectional surveys pre- and post-campaign found increased unprompted and prompted awareness and support for minimum unit pricing, bans on advertising, and nutrition labeling. Only male respondents supported changes in age limit restrictions and enforcement. However, there was no support for limiting the number of retail outlets or sales hours. This study adds to existing evidence which suggests that increasing awareness of alcohol as a carcinogen is associated with support for some regulatory alcohol policies. Next slide, please. Graphic warning labels have been found to increase quit behaviors among smokers across socioeconomic groups, in part due to their efficacy in evoking negative emotions like fear, disgust, discomfort, and worry. An online experimental study conducted in the UK found graphic warning labels on alcoholic products successfully evoked negative emotional arousal, with bowel cancer eliciting the greatest negative emotional arousal. Of the 21 warning labels, only 3 were rated as somewhat acceptable, with bowel cancer warning label the least acceptable and the lowest in desire to consume the labeled products. The author suggests that lack of awareness about the link between alcohol and cancer risk may be influencing individuals' assessment of acceptability. The use of text-only warning before introducing graphic warning labels may increase acceptability as awareness grows. On the other hand, it may be evidence about effectiveness is more important to policy setting than acceptability. Next slide, please. Using a real-world pre-post quasi-experimental design, a Canadian team investigated the impact of implementing warning labels on alcohol bottles for an 8-month period. Interference from the alcohol industry resulted in the removal of canceled warning labels just 1 month into the intervention. Despite the interruption, knowledge of alcohol as a carcinogen increased from 25.6% at time 1 to 41.6% at time 3. Consistent with expectations based on the elaboration likelihood model, the relationship between alcohol labels and self-reported drinking behavior was partly mediated by consumer attention to and processing of label messages, including talking about those labels with others. Next slide, please. Tobacco studies have demonstrated that hearing the same message from multiple sources can have additive effects. A randomized experiment in Australia compared outcomes for warning messages about alcohol and cancer delivered by a single source versus multiple sources, including mediated sources and interpersonal sources, in an online virtual environment. Participants who received messages from multiple sources in the virtual environment rated the messages as more believable, convincing, and personally relevant compared to those exposed to the message by a single source, and reported greater change pre to post on behavioral beliefs that they should and would reduce their current alcohol consumption, which supports a multifaceted approach to increasing awareness. Next slide, please. Although the focus of efforts to date has been on campaigns, 2 of the aforementioned studies give nod to the potential for interpersonal influence. Indeed, it is known that interpersonal influence of family members and friends can shape individual health decisions and health behaviors, but research has not directly leveraged family or friends in this context. Similarly, clinicians may serve as an important touchpoint for discussions that raise awareness through more personalized discussions and can reinforce clear and consistent messaging. Yet these types of conversations are currently problematic, if occurring at all. Additional research is needed to identify message strategies that may support clinicians in their conversations about alcohol with patients. Next slide, please. The ability to replicate the success of anti-tobacco campaign strategies in the aforementioned studies is not particularly surprising. A thematic analysis of websites, and documents of 27 alcohol industry organizations identified the strategies used to misrepresent the evidence about alcohol-related risks of cancer mirrored strategies used by the tobacco industry. As such, leveraging the success of anti-tobacco campaigns may provide a fruitful opening for first efforts in the United States. Next slide, please. We know that the context is essential to communication efforts. Identifying additional contextual factors that may create challenges can help us identify message strategies that have worked well in other contexts where similar challenges are faced. For example, alcohol is often used in celebratory contexts, has positive affective connotations, and is generally socially acceptable. In addition, messages about alcohol recommendations have been and continue to be inconsistent in the United States, to say nothing about pinkwashing. Dietary guidelines vary across organizations, and recommendations about drinking are inconsistent at best, as the text taken from the American Heart Association website exemplifies here. As we move towards more unified messages about alcohol, it's possible that guidelines may change. Confusion, misunderstanding, mistrust ensued following recent changes to PSA and mammography guidelines. It will be important to avoid similar outcomes if changes to dietary guidelines are made. Next slide, please. In part, resulting from the aforementioned contextual challenges, psychosocial challenges will need to be considered. For example, given positive affect and social acceptance of alcohol, messages about alcohol as a carcinogen may give rise to cognitive dissonance. Similarly, message strategies will have to be careful to avoid psychological reactance, leading to message rejection or a boomerang effect. Cancer information overload may cause message recipients to tune out additional messages about cancer prevention, while those who believe everything causes cancer are more likely to believe alcohol causes cancer. This belief may also lead to a lack of efficacy or fatalistic belief. Next slide please. While these challenges may seem daunting, we're not beginning anew. The international studies reviewed today leverage existing evidence and theory and showed promise. Many of the contextual and psychosocial challenges I described are being tackled in other contexts. Keeping that in mind, our hope is that we can have a discussion about current research gaps in communication that should be addressed so our messages can have the greatest impact on reducing cancer incidence across the cancer continuum. And so with that, I welcome questions from the audience as well as comments about how we can best address the gaps related to designing public communication efforts to address cancer, risk, and alcohol.
Excellent. And so we have our first question. What are important factors to consider when facilitating policy change? In the case of warning labels, does effectiveness matter more or does public acceptability matter more?
Thank you so much. That's a fantastic question. I think that it's a little bit of a chicken and an egg situation where in some cases it's important to increase public acceptability in order to potentially put some pressure on legislatures and policymakers in order to move those policies forward. Without the awareness first, it is harder to enact some of those policies. But on the other hand, we also know that things like warning labels can actually increase awareness as well. So it's a bit of a balancing act.
Okay, any more questions around communication? So I'm going to ask one. We've heard a little bit of a discussion, I should say, or question about, and I'll put this in air quotes, what can we learn from tobacco? What are your thoughts around the communication area? Are there lessons learned from the tobacco area? Should we be translating any of that to alcohol? Is it different?
Absolutely. I think that there certainly are things we can learn from what we've heard and what we've seen in tobacco research and tobacco campaigns. I think we need to be very aware of social norms. And that's something that, as you mentioned earlier on in the talk today, plays a pretty significant role in people's decision to drink alcohol. And so that was something initially that had to definitely be considered when we were thinking about tobacco policies. But there's plenty of other additional things that we've learned in tobacco about labeling, about graphic warning labels, and just about increasing awareness overall that can absolutely translate into the context of alcohol.
So this is a great question, and I think I'm just going to say it's about young adults, but it's to me really relevant as we think about the issues of alcohol as an addictive agent. And so in terms of advertising for alcoholic beverages such as Truly or White Claw, for example, have increased their targeting at young adults, and that some of the actors even look quite young, like in high school. What are your thoughts about how to potentially combat this?
I have to say that I think that goes back to the policy questions in part. And then also, again, awareness campaigns are important. We can draw upon some of the work that has been done in tobacco, looking at things like the Truth Campaign for potential public health messaging strategies that we could leverage that may work. Again, thinking about, social norms and not necessarily focusing on cancer risk for these particular populations, because we know that especially high schoolers are not thinking about cancer risk, and trying to get them to think about the impact of their behaviors and decisions 20, 30, 40 years down the line might be a little bit harder, a little bit more difficult. So really trying to meet our audience where they're at and coming up with messaging strategies to address their current where they're at currently in terms of their concerns and what they want to focus on.
So given social desirability, it seems like we will definitely run into reactants. What do we know from communication literature about dealing with reactants?
So reactants is something that we definitely need to be considering here. I think that we need to think about our messages that we're developing. We want to make sure that our messages are not overly direct, but this is something that we need a lot more research on in terms of the cancer context and the alcohol context, in terms of how we message to people about alcohol's association with cancer. The other thing that we can consider too is, initially it may be more acceptable and appropriate to think about this from a harms reduction standpoint. So our messages may be more focused on harms reduction and not an outright telling people to not drink alcohol.
Okay. So this is a question that I actually like and would love to hear your thoughts about. It might be difficult to reach those who drink lightly or moderately with cancer risk messaging. What are your thoughts or recommendations for light drinkers? And I'm going to add to that, what do you even think about those terms, light and moderate?
So we have to be very careful, and this is an area for future research and an area that we need to address, is to figure out, what do people think about when they're thinking about light or moderate drinking? What does light drinking mean? Does it mean one beer occasionally, during the week, or does it mean one beer a night, or does it mean a couple of beers at night, or a couple of beers on the weekend, or maybe a lot of beers on the weekend and no beers during the week? But we do need to define more clearly what we mean by light drinking and what we mean by moderate drinking. And again, I think that for recommendations for light drinkers, I would work in concert with scientists to see what their thoughts are. But I think one of the themes that we can take away is that we need to focus perhaps on a harms reduction approach, and increasing folks' awareness that alcohol is a carcinogen, and then they can make informed decisions based on that. But again, thinking about, wherever you are at, potentially drinking slightly less, and again, defining all of those terms. Again, what do we mean by light? What do we mean by moderate?
Great, thank you. Yeah, I think this is an interesting point about moderate versus responsible drinking too. Those are also interesting things to think about. Anyway, so if there are no more questions from our listeners, I think I just want to add, thank you very much, Courtney. Great presentation. And previously in the chat box, there was a question that had asked, are the cancer societies increasing their advocacy on alcohol cancer policies in recent years? So something I just want to highlight, and I can also put this in the chat box if it's not been added already, was a paper that was published in 2018 by one of our speakers today. She was the first author, Dr. Noelle Leconte, that came out of the American Society of, or ASCO, the American Society for Clinical Oncology. and it was their statement on alcohol and cancer. And to me, this was a really important paper that had come out that really helped, again, raise the flag and raise awareness on this issue of alcohol and cancer and bring the conversation to the, forward in terms of to other organizations as well as the public. So I think it's really been an important paper that came out of ASCO. I thank Noelle and then also Dr. Adina Brewster and all of the other her colleagues who were co-authors on that paper. It's really helped, I think, move the field along, and hopefully other cancer societies, will follow suit and are following suit. So with that said, I'd like to just introduce our final speaker here, my co-chair, who is, who's there? Yeah, my co-chair, Dr. William Klein, who, as I mentioned before, he's the Associate Director for the Behavioral Research Program in the Division of Cancer Control and Population Sciences at NCI. I'm really looking forward to hearing what your thoughts are, Bill, and as how we're thinking about the future of alcohol and cancer. Thank you.
Great, thank you, Sue. Let me thank you. Let me thank all of the speakers today. And thanks to everyone who's chimed in today and participated in this webinar. It's a Friday, day before a weekend. It's also before the holidays. And as I'm sure some of you are tracking in the news, we may not even be open as a government on Monday if we don't have a budget passed sometime this weekend. So for all those reasons, I appreciate you spending time with us today. Probably some of you will know that one of the things we like to do, and we feel like we do well at NCI, is plan meetings and pull together investigators from multiple different disciplines, different perspectives, different backgrounds, to approach areas of interest, areas that are important to us at NCI. You probably know the metaphor of the elephant and how different people look at different parts of the elephant. We feel it's really important to bring all of the parts of the elephant together, and we kind of are trying to do that here with alcohol, taking a soup to nuts approach, looking at etiology and epidemiology all the way up to policy and clinical effects and so on. And naturally, that's a difficult thing to do, but we are continuing to do work in this space to try to make sure we're addressing alcohol as a cancer risk factor as prudently, as efficiently, as comprehensively as possible. So if you can go to the next slide. I want to say that it's really only recently that NCI has been playing in this ballpark and thinking a lot about alcohol as a risk factor for cancer. I have to, of course, note that NIAAA, our sister institute at NIH, has been focusing on alcohol for years and years and doing great work in that space. But we have really not spent a lot of time thinking about alcohol, other than the fact that many of our cohorts, our cancer cohorts that we fund, include measurement of alcohol use routinely as part of the work that they do, and that has contributed to epidemiology. But it's clearly important to start thinking about messaging, to think about what's happening in clinical settings, think about communication, policy effects, the kinds of things we've heard about today, and we feel it's important to go in that direction. And I'd be remiss if I didn't highlight the fact that we're not the first to be thinking about this. And we have the slide here just to remind ourselves that many groups, sister agencies, professional associations, other groups have been thinking about alcohol and cancer for a long, long time. But we have now gotten into the space and jumped in head first and have been doing a lot to try to really tackle this question. And if you can go to the next slide, I wanted to just point out to you some of the things that we've been doing, including this webinar today. We've had a number of panels and sessions at conferences, Society of Behavioral Medicine, Society of Prevention Research, ASCO, APHA, and others. And we're really trying to get word out that we care about this area and would like to get more grant proposals, would like to have more buzz, more discussion about alcohol as a risk factor for cancer and how to address it. We've had a number of subject matter experts. David Jernigan spent a year with us. He spent a lot of work in the alcohol policy space and was very helpful to us. We've had a number of webinars, data resources, the Health Information National Trend Survey, which has come up a couple of times today. We have funded a number of supplements and put out some FOAs, funding opportunity announcements, one in collaboration with NIAAA. We've also had many fellows internally who have been involved in analyzing the data we've collected and also doing some reading and presenting. And then the workshop that has come up a few times that we hosted last week, and then today, of course. So I just want to end by really encouraging those of you listening to think about doing work in this area. We obviously fund a lot of work in tobacco, nutrition, UV protection, and many other behavioral risk factors, but alcohol is right there with those in terms of the importance of addressing it. And we hope to see more work in this area. So thank you to those who presented. Thanks to those of you who attended today. We will have this webinar up on our website in hopefully 3 or 4 weeks. And please be in touch with our program directors and our staff if you have any questions. And unfortunately, we don't have any more time for questions, so I'm going to sign off. Thank you all for joining us. Have a great weekend, a great holiday season, and a great 2021. Thank you all.